You are welcome to my channel. This will be a pretty quick presentation because I have a separate long presentation on MRSA. Today, it's all about how to prevent methicillin-resistant Staphylococcus aureus. Without further ado, let's go. Methicillin-resistant Staphylococcus aureus is a worldwide problem. I have a full presentation on the history of penicillin from 1928 by Alexander Fleming from United Kingdom up to where we are today when it comes to MRSA. If you want to spend your time to know everything from 1928 to date as far as MRSA is concerned, including how Staphylococcus aureus developed the mutant gene and then alter the penicillin binding protein with the capability of resisting the beta-lactam ring of methicillin, then you can click on this very link. Prevention of MRSA. Prevention, they say, is cheaper than cure. But I will add to it that it depends. What if the condition is not curable? For example, HIV is preventable, but it's not curable. So, let's waste less time. Let's go straight to the business. When there's MRSA outbreak, first thing first, let there be that communication. That is a way to prevent further spread, right? Floor manager to all members of staff should pass that information. All doctors, particularly the infectious disease experts, must be informed. All technicians were that because certain procedures are invasive and the gadget that would be used can be contaminated with MRSA. Protocol to be put in place with a written order. Why that? Verbal order may not be passed down to the other people needed appropriately. If a patient must be transferred to another hospital or unit, then the new place that will receive the patient must be duly informed. Emergency medical services personnel must be informed. Okay, prevention of MRSA will involve the case that is hospital related. In that case, we'll call it hospital-associated MRSA or nosocomial infection. We are not likely going to make that diagnosis if the patient has just been admitted into the hospital less than 48 hours. No way. But if the patient has been admitted to the hospital 24, 48 hours or more than 48 hours, then we are now making the diagnosis of MRSA, then it is hospital associated. Let me explain better again, maybe the third time. When the patient is admitted to the hospital, first thing first, we will swab the nostrils, the perineum or groin. It must be negative. If it is not negative, if it is positive within the first 24 hours of admission, it is not hospital acquired. It's not hospital associated. It is not HAMRSA. No, it is community associated MRSA. Okay, that is one diagnosis. Because part of the good preventive measures will be make the correct diagnosis so that it's not going to repeat itself. After hospitalization, in anyone without such diagnosis before admission into the facility, if that is the time the diagnosis is made, then it is hospital-associated MRSA. It can be acquired during surgery and then the individual is discharged to the community, and anyone presenting with MRSA to the hospital may present with severe skin and soft tissue infections, bloodstream infections, pneumonia, multi-drug resistant infections. Now, still on prevention, we must involve the infectious disease specialists. It is all about active surveillance. That is what will help us to prevent MRSA. Appropriate antibiotic use, accurate diagnosis of the condition, and correct treatment to eradicate MRSA. Because if we are able to eradicate it, then we will prevent further spread. Okay, before we can embark on effective prevention, another thing that we must take care of is how is this particular disease being spread from one point to the other, one patient to the other, one healthy person to another, or one healthy person to a sick person. Within hospital or healthcare facilities, members of staff could spread it inadvertently. They didn't know about it, right? It could be through surgery or through invasive procedures. It could be through contaminated devices and surfaces, meaning the table, the stool, the commode, and then the stethoscope, anything that can touch infected person and can touch the healthy person will spread it. Vomiters from a colonized or infected person or persons. Colonized persons are carriers. They are not aware that they have it, but they can spread it. Sneezing and skin-to-skin contact. Charity, they said, begins at home, but it's not going to end there. So we will take the preventive measures to the office of the physicians without telling anybody the right thing to do. We just want to ask ourselves the following questions. As a physician, am I prescribing fluoroquinolones indiscriminately? Is it okay that I should give that antibiotic to that patient? Is the antibiotic that I've prescribed not excessive? Is that an appropriate or correct dose that I should have rated? Why am I giving these antibiotics in a suspected viral illness without any evidence of secondary infection or superimposed bacterial infection? Am I trying to please this patient? Is it because this patient said, okay, the other time when you weren't around, your colleague gave me antibiotics to cover for the same signs and symptoms that I'm having right now? Or do I have the fear that if I don't prescribe antibiotics right now, this patient will walk away from me, go to another clinic and get it prescribed? Is that what I'm afraid of, and while I'm not prescribing antibiotics judiciously? Now, we should identify high-risk patients, because this will help a lot in preventing MRSA. The high-risk patient that we must make sure we screen properly when they are coming into the hospital will include anyone with positive history of MRSA, anyone who had received antibiotics in the last 3 months, anyone who had been hospitalized in the last 1 year, skin, soft tissue infections on admission, intensive care unit patients, anyone that is immunocompromised, long-term care residents, and patients on hemodialysis. They are high-risk patients for MRSA. So we will swab, we will wait for microscopic culture and sensitivity, and then treat appropriately. Screening. Yes, it's not everybody that we're going to screen, but some people must be screened. Like patient getting into oncology unit for the first time. Why that? In oncology, they cannot joke with the state of their patient because many will be on radiotherapy, chemotherapy, other strong medications that could suppress immunity and even suppress the bone marrow. And when bone marrow is suppressed, then there will be neutropenia. In fact, there will be pancytopenia, but neutropenia will be scary when it comes to infection, right? Then intensive care unit to screen all new admissions, The same at pediatric intensive care unit. If there is hospital admission recently, the individual must be screened. If there is positive history of travel to places known to have MRSA outbreak, like particular unit or a particular facility around, and the patient is coming from that place, he or she must be screened right now. If there is contact history, positive history of contact with anyone with MRSA, then you must be screened today before being admitted into the hospital. IV drug users must be screened. Patients from correctional centers like prisons, then positive past medical history of MRSA in this patient will warrant a new screening today. Prevention will also involve prevent the spread. I talked about this a little bit before. Prevent contact or decrease the degree of contact. So, personal protective equipment, gloves, glasses, gown. Then source identification and control disease. Colonized people could be healthy people, could be members of staff, could be doctors, nurses, healthcare aides, and so on, technicians, EMS people. They could be, and sometimes could be somebody that is actually sick. The colonized people are reservoirs. They are not physically down with MRSA, but they can transmit it to others. They can remain as carriers for 4 years. That is serious, right? And finally, since colonized people can remain for 4 years and they keep spreading it, we should decolonize them. So if we suspect that this person might be a carrier, from what we've gone through before now, just have the anterior nares or pharynx swab for culture. Okay? They can use chlorhexidine as mouthwash or bathe with zinc. You can have nasal mupirocin, and some centers will embark on strong decolonization therapy, combining 3 strong medications, rifampin, with double-strength Ceftra, that is called trimoxazole, and doxycycline, all to decolonize, because they are healthy. Yeah, they don't even know they are spreading it, and they will keep spreading it. With that, I've come to the end of this short presentation on how to prevent MRSA. If you want to know more, you can click on this very link. Thanks for listening. Please remember to share. I appreciate it.